Thank you to all the presenters. I'm going to ask our panelists to come up next. The panel is on inner ear imaging, state of the art. So Mary Yang's going to be our moderator for this. We have Akira Ishiyama, John Oghalai, Heidi Nakajima, and Bryan Ward. So it'll be very interesting to hear what everybody's working on.
Good afternoon. Thank you for joining us this afternoon. Okay, great. So my name is Mary Ying, and I'm the moderator of this panel. I thank my panelists for joining me this afternoon. The topic is of clinical importance because imaging leads to deeper understanding of many of our existing known otologic conditions as well as acoustic neuromas. It also provides new pathological features associated with temporal bone anatomic structures. And finally, it would apply anatomy to how we manage our patients. I would like to introduce my panelists here. First speaker would be Dr. Bryan Ward. He's a physician scientist at Johns Hopkins. His research focused on the use of 70 Tesla MRI, looking at the inner ear, specifically the labyrinth. His talk would be on frontiers in inner ear MRI, tools, gaps, and opportunities ahead. Next speaker would be Dr. Akira Ishiyama. He's a professor at UCLA. He has done a lot of work on the inner imaging for Meniere's disease. Then we're going to transit to the inner ear using optical coherence tomography to look at the cochlear duct and the cochlear structures. We'll start with Dr. Hideko Heidi Nakajima from Harvard. Her talk will title Towards Diagnostic OCT Imaging of Cochlear Structures. Then we'll transition to Dr. John Oghalai, who's a professor and chairman at USC, and he will be looking at the clinical application of OCT for imaging of the human inner ear. Before I transition to my panelists, I will give an overview of the advancement that's been made in computed tomography. As otologists and neurotologists, we depend on CT scans very much, and the high-resolution multi-slice CT has been our gold standard for temporal bone imaging. And the advantages are it's a shorter scan duration, lower susceptibility to motion artifacts. However, there are also cone beam CT that's been published, flat panel CT, which we just heard earlier. And now there's this ultra high resolution CT, and you can, depending on the detector, you can go down to spatial resolution as small as 0.12 millimeter. So it's really understanding what the detector does. I'll be talking about the photon counting detector CT in my next talk. So before I talk about that, we should look at this schematic of what CT detectors are. So prior to photon counting detectors, the A panel shows that the energy integrating detector, basically the X-ray photons come in. You have this detector that converts the photon into visible light. Then the visible light gets converted via these photodiodes to electropulse. And then these electropulse get integrated, and you get this one average projection. And so there is this high electronic noise threshold, as you can see by the dotted line. In contrast, the photon counting detector does it all in one step. So the photons come into this PC detectors, and it directly goes into the electrical pulse, and it's proportioned to what the photon energy is. So there's no averaging, so you get a very discrete energy of what that photon energy comes in, and you can see as a result of that, the electronic noise threshold is minimized, and that leads to the higher spatial resolution and the higher anatomic features. So here's a table to show the positive features of photon counting detector. So again, it's a one-step process. So there's absent electronic noise. Individual photons in different energy ranges can be counted. And it's a multi-energy imaging, so what that means is that the photons can be sorted into the multiple energy beams, and that results in lower radiation dose efficiency, improves the contrast signal-noise ratio, and lower iodine contrast material volume. And the highest spatial resolution, which I'll show in subsequent slides, is the bone, the soft tissue, and also the metal artifact suppression that will be relevant in our cochlear implant imaging. And also the use of this deep learning reconstruction algorithm that depends on neural networks, and they basically reprocess these figures until you get the best features between the signal and noise. So here's just an example of looking at the labyrinthitis ossificans, and you can see that the intracochlear calcification can be seen in panel E relative to the adjacent labyrinth that's usually hard to distinguish on what the conventional CT scan. And here are three panels here showing the differences between A is the conventional CT scan, B is the flat panel, and C is the photon counting detector CT. And because of the metal suppression, you can really see the placement of the electrode, and that will be very important in anatomic base fitting. And lastly, this is to show the detection of superior semicircular canal dehiscence with photon counting detector CT. A lot of what was read on the conventional may be overread, and in fact, there's a very thin bone that's present in these canal dehiscence cases. Okay. So I gave my brief overview, and now I will invite Dr. Ward, who will be talking about the application of MRI in the inner ear.
I think it's a different talk. Sorry, the talk should be Ward. Yeah, exactly. I don't know if I could do that one. All right, well, good afternoon. So one of the great strengths of MRI is its flexibility. By customizing pull sequences, we can take advantage of different tissue types, we can see fluid flow, and we can even begin to see molecular features of tissues. I remember being an intern and opening my first MRI scan of the brain and rapidly feeling overwhelmed. And it's only taken 15 years to finally understand why that's so powerful and that we can direct that towards understanding the ear a little bit better. So I'm going to be talking about research in ultra-high field strength scanners. These are 7 Tesla and above, and Dr. Ishiyama is going to be talking about what's clinically possible at 3 Tesla. So one of the fundamental principles of MRI is the amount of signal available is directly proportional to the static magnetic field strength. So a 3 Tesla scanner has roughly double the signal of a 1.5, and again, it's more than double for a 7 Tesla. And with this extra signal, you can trade it for either a shorter scan time with a similar resolution to the lower field strength, or what most people do is they get higher resolution scans. And so what that means is that for a cube of tissue, which you call a voxel, you get more protons in a smaller space. And so you can see finer structures, which is critical if we're going to be looking at the fine structures of the inner ear. This isn't new. So in 2015, Van der Yacht and colleagues in the Netherlands applied 7 Tesla MRI to the inner ear. But progress has been slow, and part of the reason progress is slow is that we can often build the scanner quicker than we can build all of the other components that can extract the image at a high quality. And so when we first started imaging the inner ear, like a lot of the colleagues I talked to, our inner ears looked like this, which is that you can't really see anything. And that's because of inhomogeneity of the magnetic field that happens more frequently around stronger field strengths. We've been able to overcome this hurdle mostly by the use of B1 shimming protocols. And so now consistently in all the scans, we can see the inner ears on both sides. The other thing that's changed is that there are more of these. So there are 138 7 Tesla scanners worldwide, and as of last week, there are 51 in North America. So what can we see now? So this is a high-resolution T2-weighted image in a coronal section, and consistently what we're seeing is walls of the membranous utricle and the utricular macula. We can see the turns of the cochlea much more easily now too, and what's shown here is just a histology for reference. We've begun to image some vestibular schwannomas, so this is a small intracanalicular vestibular schwannoma, and this is a patient who we identified the superior vestibular nerve as the nerve of origin, which facilitated a middle cranial fossa approach and hearing preservation. As you saw yesterday by Amin's talk, we're also using these delayed hydrops imaging protocols to look at the endolymph and perilymph as separate compartments. So we can segment this out and we can see the cochlear duct, the saccule, we can consistently see the entirety of the semicircular canals, and this allows us to generate 3D reconstructions at higher spatial resolutions. So each of these little cubes here is a voxel, which is about 4 times smaller than what you could even achieve at any resolution at 3 Tesla. And what we're seeing is the Meniere's ear is showing high drops as we expected, which is kind of a first pass attempt to show that this is working appropriately. This is a cartoon demonstrating something called the blood labyrinth barrier, which some of you might be familiar with. So the inner ear is a protected space that has tight junctions around the capillaries. It protects it from toxins in the blood from entering the inner ear. It's very similar to the blood-brain barrier. And some, including Dr. Ishiyama, have hypothesized that diseases like Meniere's disease have leakiness to the blood labyrinth barrier. And so we wanted to look at this. One of my colleagues is an MR physicist who developed a technique of doing a whole brain scan every 10 seconds, and it only includes fluid. And so what you can do is you can give gadolinium and see as gadolinium gets into the blood, crosses into these fluid-filled spaces of the blood-brain barrier. And we're applying this now to the inner ear, so we can segment out the saccule, and what you see is that the gadolinium gets into the inner ear almost immediately after IV administration in healthy controls, and it gets in more quickly, at least in here in the saccule, in patients with Meniere's disease. We can also look at this as a voxel by voxel assessment throughout the inner ear and see where the blood labyrinth barrier is and where it might be leaky in different disease states. We're also trying to push clinical anatomic imaging. So what you're seeing here is a typical angiography called a time of flight. This does not require contrast, but you can see the labyrinthine artery and the spiral medullary artery here. We often hear that MRI can't do bone, but when I look at the orthopedic literature, I see nice images of bone in the knee and the joints. And so it can, and the nice thing about it is with these 0 echo time sequences, they're pretty fast. It may not achieve the same kind of resolution as a CT scan, but we might get there someday. With ultra-high field strength at 11.7 Tesla, and this is in a temporal bone and a chinchilla, we can start to see some sensory structures even more clearly, like Reissner's membrane. We can see the cupula. And so we're starting to approach histology-level imaging. Functionally, MRI has a lot of applications as well. So this is something called diffusion imaging, applied called tractography, showing the facial nerve, and we can get even better resolution potentially at 7 Tesla with this. 7 Tesla and higher MRI strengths also unlock the ability to look at other protons besides hydrogen. So we can start to look at sodium, potassium, phosphorus, and we may be able to see sodium-potassium gradients in the inner ear. And then finally, some of you know that I study flow in the inner ear as it affects dizziness when people are in strong MRI machines. And so what we're trying to do is develop pulse sequences that have been used in cardiology to image at a high spatial resolution and low flow to see this flow that's actually happening, we think is happening in the inner ear in MRI machines. So in summary, 7 Tesla is allowing us to see things and to quantitatively assess the inner ear in ways that were previously impossible. And we're unlocking functional insights, including the permeability of the blood labyrinth barrier and possibly even physiology by sodium and potassium gradients. The nice thing about this is that it's also not just one center. This is becoming worldwide, and lots of different centers can use this technology and adapt it quickly. It's not too difficult to apply the techniques that we've shown to mitigate artifacts. So this is not done in isolation, so I work with a team of MR physicists and radiologists and clinicians that I want to thank, and as well as the funding agencies, and thank you for your time and attention.
Would you bring up the slides, please? Ishiyama, that's my last name. So we have been utilizing MRI to visualize endolymphatic high drops. Right after Professor Naganawa at the University of Nagoya published the first paper, and we immediately contacted them, and they're very generous, and they share their protocol, and we work with our radiologists to slightly change the protocol. So the reason why we can visualize, excuse me, endolymphatic high drops in human is because after you infuse the gadolinium intravenously, contrast goes only into the perilymphatic space, and the endolymphatic space doesn't contain any contrast. Therefore, you can create the contrast differential. So if you do the high resolution 3D FLAIR, as you can see right here, you can begin to see the clear distinction between the endolymph containing space and the perilymphatic space. And then when we do the multiple inversion time FLAIR imaging and the subtracted image, you can actually see the presence of endolymphatic high drops pretty well. And you can actually see the regional changes such as uticle, saccule, and cochlear duct. And we've been utilizing this probably over the last 15 years. This is a case where a patient had cochlear high drops. And you can actually see, in many cases, much better with the subtracted image rather than the straight 3D FLAIR images. And this is the case where we published the series of isolated cochlear high drops, and it may be that this is a distinct entity. We have followed some of these patients for quite some time, but I believe this may be a distinct entity. So as I mentioned, you can see it at the regional level, and this is the case that Anne Maxwell, when she was a fellow, we looked at the isolated saccule high drops, and the top one is the T2 FLAIR images, and this is the subtracted images, and this is the cystoscopographic images for anatomic comparison, meaning anything that contains fluid shows up. And you can see over here, you can see a distinct saccular high drops. What's interesting about the saccular high drops is you can have isolated saccular high drops, and you can have full-blown menial symptoms, including rotational vertigo, low frequency hearing loss, and you really cannot tell just by looking at the clinical picture. So so I strongly believe that the high drops really means the disease. In the past, it was believed that temporal histopathology shows that high drops is epiphenomena, but I don't believe so. By looking at the imaging study, it doesn't support that hypothesis. So this is a case where a patient had some of the patients are so exquisitely sensitive to a diuretic. So when we image this subset of rather small, however, group of patients who clearly responded to diuretic, you can actually see the on and off phenomena. With a diuretic, high drops goes away and the hearing improves, but you can actually see that. So in some cases, it's a dynamic process. And you can see in this case, a patient had a schwannoma, and you can actually see the presence of endolymphatic high drops over here on the side. So, this association between the presence of schwannoma and the presence of high drops is really well known. And now we are beginning to, this is still rather preliminary. Now we have a protocol to use non-contrast MRI looking at the protein and ionic contrast. So we have published our preliminary data last year, and this work is still ongoing. So to conclude, MRI can be used to evaluate for endolymphatic high drops, and you can see regional distinction. Isolated cyclic high drops can be associated with full spectrum Meniere's disease, and even including a Tomarkin crisis. And isolated cochlear high drops may exist clinically. Thank you for your attention.
So the next slide should be Nakajima. Where do I point it? There?
We gotta get the slides up first.
Oh, okay. Actually,
Red is backwards.
hi. I'm going to be describing some of our work where we're hoping to work towards diagnosing cochlear anatomy with optical coherence tomography. And what optical coherence tomography will do is it can visualize through tissue. And here you can see this is the middle ear cavity, the middle ear ossicles. This is the cochlea over here. And you can see part of the round window. And we're going to be looking through the intact round window. And we want to see a section here. So we're going to be looking into the screen. So that arrow corresponds to the arrow up here. The round window is right below it, and then you can see under scala tympani the cochlear partition. So this is the kind of view that we can get. So this is, it's here again, and we flip it like this to a position that we're used to looking at, for example, in cross-sectional histology. You can see the osseospiral lamina here, which is bone. This is the bridge, which is a soft tissue section between the bone and where the basal membrane starts. Right here, you can see the collagen fibers lighting up in orange, the reticular lamina with the cuticular plates of the hair cells, the tectorial membrane interfacing really closely to the hair cells, and the limbus over here. But you can see that this kind of view of the cochlear partition is kind of grainy, and it really depends on the reflectivity of the different tissues. And it's sort of like ultrasound, but with this technology, we're using light. So what we want to do is we want to be able to understand the structures so that we can, say, diagnose the anatomy of the cochlea in a particular patient. So in these examples that I'm showing you, they're in very fresh cadaveric specimens. Usually around 10 hours post-mortem, we start to do the OCT imaging. And but what we see, as I said, it looks like this. And what we do to interpret it, we get a histology that is very similar. And that helps us understand what kind of structures that we're looking at. This is superimposed over the OCT image. Now, we're not the only group trying to do this, trying to work towards anatomical diagnosis. For example, Tina Stankovic has done amazing work in this direction. Nicholas Verhart in Zurich is working on that. You'll see that John Oghalai is also working towards that. So hopefully, we're all working towards being able to do this well. Now, on the left here are examples of histology of different types of conditions. And this is very similar to what Charlie Lieberman recently published, looking at histology and then rating them with an integrity score. And we can do that also with OCT. So here, this looks pretty normal. Here, you can see this big hole there, right? That is the absence of outer hair cells. And we see something very similar in OCT. The organ of Corti here is shortened, and we see that in OCT, as well as those that have no organ of Corti. So you can imagine with treatments such as otoferin, you really want an ear that looks more like this, right? Because the synapse is the only part that it can really treat. While stem cell treatments can possibly treat and grow outer hair cells, but you would want something that looks like this. Well, with this, it's not going to work. So it could be very valuable to be able to determine that. So we've also done histology in the contralateral side of these ears that we did the OCT, and it gives us a little bit more faith in what we are seeing, because here you can see sort of like a Henson cyst, and we see that in histology. And, but those histology takes over a year, and we are very impatient. So now we're working with Andreas Eckhart, who is working on a very fast method of histology, less than 2 months. And here you can see an example of that. We're playing with different kinds of stains and lighting and so forth to be able to really look at details of the cellular structures and even stereocilia. So thank you.
Okay. All right, good. Thank you. Well, I guess while we're getting set up, Mary, thank you for inviting me. Bill, thank you. This has been a great panel so far, and hopefully my slides will come up and we'll take a look. We've been doing OCT in our lab for almost 20 years now, and slowly it's gotten smaller and smaller and much less expensive, and we've started to move towards working in our patients. And just last year we started a company. There's no money in this company, but we have started it. My collaborator, Brian Applegate, is a bioengineer, and you can see a mouse cochlea here. And you see the microscope we use. It's just a dissecting microscope, and we anesthetize a mouse, open up the bulla, and we can look through the otocapsule bone and see a really good view of the cochlea. And it literally takes, well, this volume picture, it's scanning. We can collect about 5 volumes a second right now, so it can collect data very fast. And we had a postdoc in our lab, Jink-Young Kim, who used this technology to image the mouse cochlea after noise exposure. And I think you can see the 3 scala here and some kind of grainy pictures of the organ of Corti. The tectoral membrane is really clear. Reisner's membrane is really clear. So I want you to watch this next movie and see in the middle image, see the Reisner's membrane after a loud blast. And you see the development of endolymphatic hydrops between hours 1 to 3 after the blast exposure was completed. And so when we saw that, we thought, well, you know, could we use this to diagnose endolymphatic hydrops in patients? And so we built a system on an old Leica microscope that nobody was using anymore. We basically built a big adapter in front of the microscope lens, and we started using it on our patients. And Weihan and Zahan were the 2 engineers that really designed and built this thing. Dorothy is our fellow who really collected the lion's share of the data, working with all the neurotologists in our clinic. And Marcella was a medical student on a 1-year rotation with us. And so the first thing is, well, we just used it and looked down the mouse ear canal, and you can see the eardrum, the tympanic membrane, and you can see through the aortic capsule bone, you can see into the cochlea really nicely, right through the promontory, and you see Reisner's membrane there. But when we did it on a human, you see the tympanic membrane's thicker, you can see the promontory, and maybe we're seeing through the promontory a little bit, but we're just not seeing the structure inside yet. And so the dense, not only the bone of the aortic capsule is thicker, but also the spiral ligament is right there, and so you have to see through a lot of tissue. And so what we decided to do is start off a little easier. We thought we'd do it in surgery and look at the semicircular canals where there is no spiral ligament. It's just the bone. And so as a start, here's Dorothy operating. She would just blue line the semicircular canals during a translab approach to an acoustic and then collect an image. And the green outer box is the box that we're scanning with the OCT device. And you can see in part A there, you see this is kind of a non-phos view, just like that green box, where the lateral semicircular canal can be seen and the posterior semicircular canal can be seen. And if you look at the red dotted line, it goes over to part B. That's kind of an XZ cross-section, and so you can see in depth. And you see the lateral semicircular canal, and you can see a line inside separating the endolymph from the perilymph. That's the E and the P. And if you continue towards the right, you see the posterior semicircular canal, and you can get a kind of a cross-section of it there. Again, seeing the endolymph, or the membranous labyrinth and the boating labyrinth. Similarly, you get a cross-section of the posterior canal the same kind of way. And so this got us excited, and so we started a small trial with the hypothesis that patients with Meniere's disease that we're operating on to do an endolymphatic shunt should have endolymphatic hydrops. And then we also do a lot of acoustic neuromas, and it's been shown that patients with acoustic neuromas often have endolymphatic hydrops. So that was our hypothesis, that they're going to have more endolymph relative to perilymph compared to controls. And so as controls, we took patients that we were doing chronic ear surgery on, doing a mastoid, and could take a look. And so we enrolled 6 control subjects, 4 with Meniere's disease and 9 with vestibular schwannoma. And so here's some example of data. So you can see we have an automated way to measure the bony labyrinth fitting the contour with an oval, and the membranous labyrinth similarly. And then we could measure the endolymph to perilymph ratio after calculating those 2 cross-sectional areas. And well, in this example, you can see the endolymph to perilymph ratio was larger in the vestibular schwannoma patient compared to Meniere's disease and control. And this is the data that's confirming that. So the lateral semicircular canal is on the left and the posterior semicircular canal is on the right, and the data are the same, where the blue control patients have a lower endolymph to perilymph ratio. It goes up in patients with Meniere's disease, and it's even higher in patients with vestibular schwannoma. Just to see if our measurements are repeatable and valid, we just repeated the same measurements multiple times in the same patients during surgery. And that's what the plot on the left is. And basically every patient there is listed. And you see that there's not a lot of scatter within patients. And similar, the intercanal correlation is quite good. So if you compare the lateral canal to the posterior canal, there's a good correlation between the two. And lastly, we just looked at the auditory thresholds and see do they correlate with endolymph to perilymph ratio. And there's a pretty decent correlation both in the lateral canal and the posterior canal, too. So their auditory status kind of correlates. So just in conclusion, our data show that at least at this point, OCT can see into the inner ear, it can image the membranous labyrinth, and this is something that, although the MRI images are spectacular, they can't actually detect the membranous labyrinth within the arc of the semicircular canals because it's so small. And so it just shows you the resolution of this technique is incredible. But the problem is the depth limitation, and the penetration through bone and through tissue is definitely an issue. But it would give us a way to start testing therapies and see if the amount of endolymph a patient have decreases, especially if we could use this in the clinic. And so, we're getting pretty close. We have a handheld one, we can use it in the clinic, and we're almost to that point, so, well, we'll see. We have a big team of people, and I'm just privileged to work with the neurotologists in our group. A lot of the data came from my patients, but most of it came from their patients, and with Dorothy collecting it, as well as a big research team. So, and I also want to thank the NIDCD for supporting this work. Thanks.
All right, thank you, panelists. That was great. I would like to open to the floor, audience, questions.
Dennis Poe in Boston. Terrific talks all. To Bryan Ward, I've heard anecdotal reports that there can be perceptual distortions in these high Tesla fields, like visual distortions. Have you encountered any of that?
Yeah, thanks, Dennis. So we've been looking into that for probably like the last 10 years or so, and people who go into strong MRI machines, they often will experience a sensation of rotation that's temporary. It lasts about a minute or so, and then it goes away. We think it's because of the interaction between the static magnetic field and the ionic currents going through the vestibule, and that creates a force that pushes on the fluid and creates that sensation of rotation. But as long as your eyes are open, it seems like that helps kind of suppress the sensation of dizziness, and by actually going into the scanner more slowly, that also eliminates it. We just have to get a special button that says go in over 2 minutes, and that should take care of that part of things.
Great, thank you.
Michael Seidman from Orlando. Dr. Oghalai, really pretty pictures of the endolymphatic eye drops after noise. Is that glutamatic cytotoxicity? Is that dark cells secreting more endolymph? Is that lipid peroxidation? What is the mechanism of that? I didn't realize that there was an increase in endolymph after noise, and we've done a lot of studies, and I've not seen that, but that was a beautiful picture. So why?
Yeah, thank you. Yeah, we've done a lot of the basic science to get at the mechanism of this. And it looks like noise trauma damages the mechanoelectrical transduction channel, and so it closes, and so there's a loss of potassium recycling. The potassium builds up in the endolymph, raising its concentration with an osmotic effect, so then water will flow from the perilymph into the endolymph.
So it's a closure of the gate, basically?
Yeah, and it resolves with time as either the ear accommodates and secretes less potassium, or as the transduction channels reopen again.
Have you seen
One of the interesting things is that sense of ear fullness you might get after going to a loud concert is probably that.
So that was going to be it, is PTS, permanent threshold shift versus temporary threshold shifts, and that might be part of it too, it sounds like.
Thank you.
I have a question for the entire panel. That is that the increased resolution is, of course, a great pleasure to look at, and it's very satisfying. And I'm wondering if instead of if the time is coming when we'll just have the images or the information, not even images, analyzed, and then the machine gives us an answer. So we know, we bypass this experience of looking at the images and seeing the endolymph or seeing the ossification. Instead, it just says, yes, there's ossification, or yes, there's increased endolymph in the sacule. I mean, it's kind of a horrible thought, but do we really need to have the pleasure of looking at the images?
Well, hopefully the day comes soon, but I kind of doubt it, because not in the immediate future, because we have actually done a three-dimensional reconstruction of, we're going to have a presentation tomorrow looking at what it means to have high drops by doing a three-dimensional reconstruction of high drops using archival human temple bone specimen from patient who had Meniere's disease, and we made a comparison to the clinically obtained images. And there is a limit of what you can see using today's resolution. So to answer your question, some people may think that you can apply AI or that type of stuff, but the resolution is not there. We're not even close.
Dr. Hopper?
Bryan, in the entire panel, wonderful work. Bryan, how long do those 7T scans take?
So, so it depends on the pulse sequence. So an anatomical scan, like the heavily T2 weighted, takes about 10 minutes, which is similar to what it is for the 3 Tesla, similar resolution. Same thing for the flare. But there are shorter scans, like the flare image that we get takes about 2.5 minutes. So.
And are you doing fluid analysis on those scans as well? I know you can modify the 3 Tesla, but.
Yeah, we haven't looked at fluid flow at 7 Tesla yet, because we would need a programmer to change the pulse sequences. But we've been using it at 11.7 Tesla and getting those grids, and you can see fluid movement. It's just not set up yet at 7 Tesla, so it requires some more development.
Thank you very much. It's wonderful work for all of the work was great.
Okay, thank you, everyone.
Yeah, I'd like to express my appreciation for not only coming on and participating in the panel, but for all the work they've done. Can we just give them another hand? I mean, this is just amazing work that they're doing. On behalf of our specialty, and it's